Welcome. I'm Dr. Andrew Williams, one of the clinical directors in ECIST, the Emergency Care Improvement Support Team, and I work as a geriatrician down in Dorset. With me is one of my colleagues, Amit. I'll let you introduce yourself, Amit.
Hello, my name is Amit Arora, and I'm a consultant geriatrician in the Midlands region and also a regional clinical director with the Emergency Care Improvement Support Team. Welcome.
Welcome. So we're here today to talk a little bit about the new guidance that ECIST published about helpful approaches and practical tips to improving discharges on Pathway 0 and Pathway 1. Amit, can I just ask you just to give us a little bit of context about why this has come about and what's happening now that's made ECIST produce this guidance?
I think it comes as no surprise that the Omicron variant related patient demand, the staff sickness and the absences related to the self-isolation requirements on a background of unprecedented pressures within the health and care system require an urgent response to reduce the likelihood of harm occurring to patients as well as staff. We know that the vast majority of patients in our acute hospital beds could potentially go home without any care and support. It does not always happen. These patients largely are classed as Pathway 1 or Pathway 0 patients, and it makes perfect sense that at this time of huge pressure, we focus on these particular patient groups and maximize our efforts to get these patients home so that the patients who are waiting in the community, the patients who are at most risk of harm from non-availability of healthcare resource or bed, if required, can be attended to at the right time. So, Andrew, a lot of our colleagues up and down the country will be thinking, why are we now focusing on Pathway 0 and Pathway 1 instead of Pathway 2 and 3?
So I think historically when we've run MAID events and perfect weeks, we've often looked at how do we unblock those really complicated discharges. And I think one of the issues we're very aware of at the moment is the real crisis in the social care workforce. And so we've shifted our emphasis about how can we think about those people who have less complex discharges, some of those more simple discharges, but also asking some questions about can we do things differently once people are in hospital. And one of my colleagues always uses the question about if that patient today presented, would you admit them? And if you wouldn't, should you still be keeping them in hospital? Or could we think about doing things differently with virtual wards or ambulatory clinics or alternatives to admission? So it's looking at those simple discharges rather than getting really hung up about those small numbers of really complex discharges.
That makes perfect sense, isn't it?
In this, we look at people with a low news score, and I've heard clinical colleagues of mine say that's not what news was designed for. It wasn't there to predict people could be safely discharged. It was there to spot deterioration in patients. So can I just ask, why are we using a low news score for this, and what's the aim of using that?
Yeah, so the news score is not designed to discharge people. It's only a clinical assessment score, and nobody is saying that anybody with a low news score should be discharged home. Quite the contrary. I think it's a useful steer. It's a useful time when you look at the news 2 score to initiate a clinical conversation or a clinical mindset that, oh, well, okay, if the clinical news score is less, is there a reason why this patient should stay in the hospital? It just triggers a thought in our minds.
So are we saying that that's just the basis and they're the patient groups to start that clinical conversation about, but why do they need to stay in and what could be done differently, rather than we're trying to say everybody with a low news shouldn't be in a hospital bed?
Absolutely. So we are not saying that nobody with low news score should not be in a hospital, but it should be used as a trigger question, which should start the thought process in our own minds and our own clinical team's mind. What is it different that we can do to enable this person, if suitable for discharge, to go home? So it should just be used as a trigger question.
Over your time, you've run lots of MAID events and perfect weeks and things like that. What do you think are the key factors for success in making these work?
I think that every team, every department, every clinician, every non-clinician has a role to play and think differently as to what they can do differently to create that capacity within the system. I think for clinicians, we need to start thinking in a different way as well. What can we do to facilitate the discharge to home sooner? What can we do today to make that happen today? So have we thought about a virtual ward scenario? Have we thought about a same-day emergency cares? Have we thought about an appropriate follow-up? Have we tried and reserved that CT scan slot, which is available for 2 days later? If the person goes home, will the radiology department keep that CT scan in 2 days' time still as an outpatient? Have I made appropriate arrangements to follow up that CT scan report in good time? So it's nobody's being prescriptive here. We don't want to tell anybody what to do, I think, but we do want people to start thinking a little bit differently as to what more can be done, what can be done differently. That's the idea.
Thank you very much. That's been great. That's been really helpful.